Good evening, everybody. Today we shall be discussing how to monitor the treatment of TB. There are three important things in monitoring. One is clinical monitoring, the second is radiological monitoring, and third is bacteriological monitoring. Of these three things, the most important is bacteriological monitoring, but it is difficult in a sense that you don't get the proper samples, and even if you get the proper samples, they are paucibacillary. So most of the tests are negative. But anyway, we have to do these three. The first thing is, when should we do the monitoring? Once you start treatment, it is better you ask the patient to come after 2 weeks of starting treatment. And thereafter, at the end of first month and every month till the end of therapy. And after the end of therapy, you ask the patient to come every 6 months for next 24 months. In the first visit that you ask the patient to come after 2 weeks, you recheck whether the patient is taking the correct dose of the drugs, correct combination. And on each visit, you should emphasize to the parents the importance of adherence to treatment and completing the treatment. And every day, the drug should be taken, and under no circumstances it should be missed. And these are the very important things you should tell. And also you should tell how to identify any side effects if the patient develops at all. Of the clinical assessment, first of all, you should see the appropriateness of the therapy, whether the child is taking all the drugs in desired dose, whether the child is tolerating all the drugs, whether he is developing any symptoms. Next, you see the response, the symptoms with which the child has come, whether the cough has come down, whether the fever has come down, whether the size of the lymph nodes has come down, whether the chest findings in pulmonary TB has been corrected. So response of therapy is very important. And regarding the radiological assessment, usually if the child is doing well, we don't do a repeat X-ray, but we do like to do a repeat X-ray at the end of the therapy. But if there is deterioration, then we do earlier. And regarding the microbiological reassessment, we usually do at the end of intensive phase. That means after 2 months, and then again at the end of therapy. We'll come a little bit in details. So radiograph, as I've told you, follow-up radiograph should be done usually at the end of IP if there is persistent symptoms, or if there is any deterioration. Even after 4 weeks of therapy, you can do an X-ray chest or X-ray of whatever parts you are dealing with. But later we do at the end of continuous phase. Of the microbiological assessment, it is very important. You should do a smear and culture. CBNAT is not the test for microbial assessment, because CBNAT will pick up both live and dead bacilli. And we want to show that the child does not have any live bacilli. So that's why it is the smear and culture is most important. And we usually do at the end of intensive phase and the end of the completion of treatment. But if there is any failure in response, even after giving 4 weeks of therapy, then we'd like to do. Also, you should see whether the child has any comorbid condition, because if you don't treat comorbidity, your child will not show improvement. For example, TB and HIV goes hand in hand. If you don't treat both, you don't expect any improvement. So see the comorbid condition like HIV, severe acute malnutrition, and also see what are the drugs, just like in neurotuberculosis, anticonvulsants, drugs to reduce intracranial tension. So these things you have to see. And lastly, what is very important, the adherence of therapy is very important. Otherwise, your treatment is not going to succeed. So on each visit, pill counts, and also if you report the case to a proper authority, then treatment supervisor will also take care to this adherence of therapy. So most commonly, we expect that the child will show deferred vessel, that is fever and cough are first to come down. They usually take 2 to 4 weeks to respond, but at times it might take a little longer. Weight gain is usually we see after 4 weeks, and quite a good number of patients, for example, 20–25% might not show weight gain, but the other clinical symptoms should improve. And if there is any delay or deviation in these things, you should be suspicious and you should try to investigate why such a thing has happened. So the most important thing when you monitor a case, if you find that the child is not responding, the desired amount of improvement you expect, even after giving 4 weeks of therapy, it's not responding. So what do you do in case of non-responding TB? So there are a few important questions to ask before you take a decision. First of all, is this a true non-response? Supposing a persistence of cough or some chest findings, supposing air entry in some place of the chest is persisting even after giving 4 or 8 weeks of therapy. So you should think whether it's a true non-response or it might be a sequel of the condition child has developed. The child might develop permanent fibrosis with loss of lung volume and some amount of compromise of the air entry. So first of all, you think whether it is a due to non-response or it's a sequel of the condition the child had, or whether the child has any secondary infection. If the child has secondary infection, the fever might come back, the child might not eat properly, the test signs will also come back. So first you take this. Next you see whether the child is taking correct treatment, correct dose, correct duration, whether the treatment adherence is there. So you should check that. The third important question you are going to ask, that whether you are dealing really with a case of TB or non-TB. There are many conditions which mimic TB. For example, I've told you before, HIV is one of the conditions, cystic fibrosis, pulmonary aspergillosis, sarcoidosis. There are many other conditions which mimics TB like anything. So you have to first ask them whether it is a true TB or non-TB. Is there any something which we have missed, some comorbid condition? I have told you before, TB and HIV goes hand in hand. If you don't treat both of them, if you treat one of them, it is not going to improve. So you have to see whether there is some unaddressed or unidentified comorbidity is there. So that, and the fourth important question, is it a paradoxical reaction? What happens in paradoxical reaction? Tuberculosis depresses the immunity of the host. And when you start treatment, the host immunity gradually increases. And there is an immune inflammation. And this immune inflammation might cause lesions where previously it was not there. So there might be appearance of new lesion. There may increase in the size of lesion. So these paradoxical reactions are seen in case of TB after starting treatment. They don't require any special, all you have to do, continue treatment is going to settle in time. But at times we must do something. And this one of the very important thing of this paradoxical reaction in TB, how does it differ from paradoxical reaction in HIV? In TB, if you have a paradoxical reaction, the signs and symptoms of TB or the systemic symptoms of TB, they are not there. The child will have new lesions, but the child will not have fever. The child will not have cough. So this is a very important thing. The systemic signs are not there, but there might be some increase in the size of lesion. So the fourth question is whether it is a paradoxical lesion. And after taking care of this that your diagnosis of TB is perfect and it is not responding even after addressing the comorbidities, other things, and despite giving correct therapy, then only you should think of you are dealing with a case of drug-resistant TB. Most commonly because of poor regime, adherence, these things will take. Drug-resistant TB is so important, it is not always the cause of non-responding TB. So you should remember this. So let us take a illustrative case. So 8-year-old boy has come with fever, high grade, which was documented, cough, persisting dry for last 1 month. There was no history of contact with a TB patient. And this was the first X-ray, which shows the right side of the lungs is involved. The lower part of the upper mid zone and lower zone of the lungs is involved. The costophrenic and the cardiophrenic angles are obliterated, so there might be collection of fluid. The child was started on ATT, anti-tuberculosis therapy, and after 1 month from August to September, a repeat X-ray was done, and again it didn't show much improvement. Only that this non-homogeneous opacity is persisting. This cardiophrenic, costophrenic angles was not clear. So there's not much important improvement in radiology also. So now after 3 months, the treatment started in August. Now it is November. The child has come to you for an evaluation after 3 months. So now when you started evaluating, you find the child was on anti-TB therapy, but on what basis? TST, tuberculin skin test, was not done. Gastric aspirate or sputum was not done. Pleural tap was not done. But now when you examine the child has some cough, was looking well, was afebrile. There's no lymphadenopathy, no clubbing or pallor. On chest, percussion was impaired on the right side, and definitely you can see the right-sided volume loss. The right-sided ribs are crowded as compared to the left side. And in the left side, there is air trapping also. So right-sided volume loss and air entry in the entire throughout the right side was equal. So in this, now when you have taken the history properly, very two important things you can see. In spite of non-improvement of radiological X-ray, the child is looking well and the child is afebrile. The child does not have any lymphadenopathy, pallor or anything. So you should take these points very cautiously. These are very important points. So what are the possibilities? Is this a non-response due to drug-resistant TB? Or it's a persistent radiological shadow due to sequelae? So what we did, so we again investigated the child. There was no sputum production, so we had to do a gastric aspirate. It was negative for smear. X-ray chest was done. It shows the same finding as before. A USG was done, but it showed minimal pleural fluid with septation, and the pleural fluid was such small in quantity that it was not possible to tap and bring out the pleural fluid. So it was thought to do a bronchoscopy. And on bronchoscopy, it was found caseation in the right upper lobe bronchus completely obstructing the opening of the anterior segment, right lower lobe dry, dirty mucosa, and right middle lobe compressed from above. The bronchoalveolar lavage was sent for AFB, CBNAT, and Mycobacterium growth indicator tube, liquid culture. These three things were sent. So what we found in the report, we found that AFB stain was negative, gene export was positive, rifampicin resistance was not detected. As I've told you before, CBNAT has not much role in follow-up of cases, but as it was not done previously, so at least CBNAT does not tell us whether it is a live or dead bacilli, but it tells us one very important thing, that rifampicin resistance is not there. MGIT was sent for drug sensitivity testing and later came as no growth. So what we did, we continued the treatment 2 HRZD, 4 HRD, but this time we added steroid. And after adding steroids, after 2 months, we saw that the child is looking well and is afebrile. So this is the X-ray which was ultimately there. So what happened in these cases? There was caseation tissue and other things which was obstructing the bronchus. So it was a sequelae. All he needed was giving such steroid. So true non-response can be only established by microbiological diagnosis. In drug-resistant TB, attempt of microbiological diagnosis was always should be done, and appropriate therapy in such cases was 2-HRZE, again with steroids. So once the steroids are given, the child showed very good improvement. So let us take another important case. A 6-year-old child has come with right-sided pleural effusion. Both the cardiophrenic and the costophrenic angles are obliterated, and rest of the thing, the left lung is normal. So 3.5 years, the child is on anti-TB therapy, and 3.5 years later, a routine X-ray was done due to some cough, and the routine X-ray now showed there is some sort of non-homogeneous opacities appearing on the right upper field or the right upper lobe, and effusion has improved. You see the previous X-ray, the previous X-ray effusion was there. Now it has improved. Microbiological examination on gastric aspirate was done. It was negative. So a fibro-optic bronchoscopy was planned, because why the children, after though the effusion has improved, should develop a new lesion. So on doing the fibro-optic bronchoscopy, what we found, a hypertrophic granulation tissue at the right upper anterior segment. And once the granulation tissue was removed, the child improved, and bronchoalveolar lavage shows AFB negative, and there's no change in treatment done. We continue with the treatment given. So these are the two very important cases which showed, though it will appear as a drug-resistant TB, but these are not drug-resistant TB, but these are sequelae. So whenever you see a fresh radiological lesion, new lesions like nodular opacities can be seen after effusion has clearing, and it is not uncommon with pleural tuberculosis pleural effusion. And also some patient on ATD might develop pleural effusion on treatment. So it is not always due to non-response of therapy. So to diagnose a drug-resistant TB, you have to not only grow, but you have to show live bugs. And to show live bugs, you need to do a culture. So investigate and demonstrate resistance, utilize rapid diagnostic when possible. And if you are unable to show live bugs, most likely it can be a paradoxical reaction. So what is a paradoxical reaction? As I have told you before, the TB decreases the immunity. Once you start anti-TB therapy, the immunity of the host increases. And as the immunity of the host increases, there might be enlargement of the older lesions, appearance of newer lesions. Most of the paradoxical response are usually seen after few weeks of therapy, mostly after 3 weeks, and it might continue till 12 weeks of therapy. And most frequently it is seen between 6 to 7 weeks, and it can last for more than 2 months. Generally, most of the paradoxical reactions are self-limiting. They resolve without sequelae, but there might be wide variation in the time of their appearance and how long it is going to last. And usually you need not do any change in the whatever drug regime you give, you continue with that, but it's going to improvement. It usually occurs during treatment, but in case of lymph node TB, the size of the lymph nodes even might enlarge after quite a long time, as late as 2 years. So you should, paradoxical lesions are usually seen. We'll come to the next. These are also known as paradoxical upgrading lesions. They are usually seen in increase in the size in the mediastinal lymph nodes or in the pulmonary infiltrates in pediatric TB with primary TB, appearance of new lung infiltrates in extrapulmonary TB, development of new pleural effusion, increase in the size of effusion, appearance of effusion on the contralateral side. All these are things. Appearance of new lymph node or original or enlargement. Similarly, in case of central nervous system TB, you can see appearance of new tuberculoma or increase in the size, infarction, hydrocephalus, all these things. Again, I reiterate that in these paradoxical lesions, though you see new lesions and an increase in the size of the lesion, the systemic symptoms are usually not there. That means that the child fever has gone away, the child's cough usually has gone away, the child is started gaining weight, has started having good appetite. In spite of all this, there are new lesions or increase in the size of lesion. Then you think that you are dealing with a paradoxical response. So now what might be the reasons of symptoms persistence or recurrence of symptoms in a patient who is on appropriate TB therapy? So first might be the poor drug diagnosis, or diagnosis is not correct, or regime or adherence to treatment is poor. Or you might have a superadded infection. It can be sequelae, as I've shown you the two cases, or comorbidity. The most common comorbidity in case of TB is HIV. You should think of it. Or there might be a paradoxical upgrading lesion. If you have excluded all this, then last will come the drug resistance. So monitoring and ensuring adherence is very important. And nowadays we give direct observed therapy. Usually the mother of the child is your family who is supposed to do this observation. There, if you are proper, your child is properly notified, the parents will receive SMS texts regarding confirmation and reminders. And whenever they will go to collect fresh medicine, they will see the pill counts, and so many things has been done so as to ensure that the child properly adheres to the treatment. So to sum up the whole monitoring, the initial visit should be within 2 weeks of start of therapy, and emphasis might be laid on ensuring completion and adequacy of the therapy. Sick babies and caregivers often need support in the initial phase so that they are able to adhere and complete the therapy. Follow-up of children is most important with the pediatrician, even if the child is being treated from the DOT center. So you have nurtured the child since birth. Now, even if the child is getting drugs from some other place, it is your duty to do a follow-up. And once you do the follow-up, the parents, they feel immense relief that my child is in safe hands. So follow-up should be done by the pediatrician. Follow-up after 1 month at the end of IP, I have told you this thing, microbiological test should be done at what time I have told you, and routine repeat X is not needed except at the end of the completion of therapy. So now let us see a few cases, what happens if there is interruption of therapy. A child, 4-year-old female child, presented with fever, cough, and weight loss. The mother was on anti-TB drugs for 5 months. The child was started on anti-TB drugs for pulmonary TB, CAT1, that means 2-HRZD and 4-HRE. And there was on the X-ray, there's some abnormality seen. He has completed 3 months of treatment. The child has completed 3 months of treatment, and thereafter the child has went to his village. And on going to the village, as the child didn't have any symptom, the mother, after taking 3 months of treatment, has stopped treatment. So what the child has taken? The child has taken 2 months of intensive therapy and 1 month of continuation therapy. Now, after 3 months, he stopped therapy for 1.5 months. That is 1.5 months he has stopped taking treatment. And now, after 1.5 months, the child has again started developing cough, fever for the last 1 week. So the patient has now come back to you. How will you manage this patient? The patient was re-investigated. On examination, we found that she had crepes on the right base. She was treated with oral amoxicillin as a diagnosis of community-acquired pneumonia was thought, and also investigated for active TB. For active TB, we had X-ray chest and gastric aspirate for AFB, as well as CBNAT, that is gene expert, was done, which was negative. TST was not repeated as it has no role in diagnosis of a previously treated cases, but already TST will be positive. She has improved on antibiotic therapy, but now the mother is worried that what will happen to him because he has not completed. He has taken only 3 months of therapy. He has not completed a TB treatment, and the mother is now worried. So what we have told you before, for interruption of 4 weeks, if the child has taken treatment up less than 4 weeks, we can take them as we do not do anything. What we do, we simply resume the therapy. If the interruption is less than 4 weeks, we resume the therapy. And as taught previously, we don't give those extra days which the child has missed after completing 6 months. So all you have to do, you start therapy and complete the therapy by 6 months. You don't have to give any extra day of treatment. But if the interruption is more over 4 weeks, then in all cases, you have to reinvestigate whether the child is suffering from drug-resistant TB. So more than 4 weeks of interruption should be reinvestigated whether the child has developed drug-resistant TB. On reinvestigation, if rifampicin resistance is not detected, then retreat as a new case with first line 4 drugs. And not only that, you have to check whether the child has developed any INH resistance. And how do you do this INH resistance? You do it by type 1 line probe assay. And if resistance is detected to INH, his rifampicin resistance is not there. But now on further investigation, if INH resistance is detected, then we give a special therapy which is known as INH mono or polyresistant therapy, which we will be dealing with when we deal with drug-resistant TB. So this is what happens if rifampicin resistance is not detected. And if rifampicin resistance is detected in a child who has interruption for more than 4 weeks, then he will be treated as a multi-drug resistant TB. Now, in the case of interruption has occurred in the CP, that means in the continuous phase, and on retrieval, the patient shows no evidence of active disease and the tests for drug-resistant TB are negative, then what we can do, the remaining treatment course might be completed. So where from he has left, the rest of the course we are going to complete, because two very important things we have found out. The child does not show any evidence of active TB, and neither the child shows any positivity for drug-resistant TB. So whatever, and he has left treatment in the continuation phase. So whatever treatment was left, we will complete that. Our illustrative case falls in this group, so we will give and complete the rest of the continuation therapy. So another very important thing, that how do you monitor and manage the adverse effects in case of TB? So as I've told you, there are 3 types of monitoring. We do a clinical monitoring, which is very important in case of adverse effect. We usually don't do any routine laboratory investigation to pick up any adverse, routine laboratory test to pick up any adverse. We inquire about the symptoms at every visit, and also we should teach the parents how to detect the common adverse effects is seen. One of the most common adverse effects when you start anti-TB therapy is discoloration of the body fluids, starting from the tears, urine, even the sweat. So you have to explain that this is very common, and parents often they get frightened by seeing this. So on each visit, you should also train them how to detect adverse effect. So for detection of adverse effect, we mainly do what clinical monitoring we do. And if clinically we find some abnormality, then we go for routine laboratory. Otherwise, you don't do any routine laboratory tests. So all the drugs which you use, first line drugs, they have a common side effect, that is nausea, vomiting, these things. So often we have to take proper precaution for these effects. Isoniazid is especially notorious for hepatotoxicity, skin rash, and peripheral neuritis. Rifampicin, I have told you before, it causes hepatotoxicity, discoloration of the body fluids, and rifampicin hypersensitivity rashes are also common. Pyrazinamide is also another drug which causes hepatotoxicity and joint pain. Ethambutol causes retrobulbar neuritis. It has been said that it causes, but the cases in real world is very few. We have used ethambutol right and left for such a long time, and very few cases you will come across this ocular toxicity with ethambutol in the dose what we use. And all you know, streptomycin can cause both vestibular and ototoxicity. So let us take one of the very important adverse effect in case of TB is acute DILI, that means drug-induced liver injury. And to diagnose DILI, either you should have a clinical jaundice or your total bilirubin should be more than 1.5 milligram per deciliter. And without any symptom, if the rise in AST and ALT is more than 5 times of the normal limit, or in case of symptoms like nausea, vomiting, diarrhea, if the rise of ALT or AST is more than 3 times. So if it is a symptomless rise of more than 5 times, if it is a gastrointestinal symptom, then rise of 3 times, or if you have a clinical jaundice or bilirubin is more than 1.5, you can take it as a drug-induced liver injury, DILI. So most of the cases of DILI, the common features will be nausea, vomiting, anorexia, diarrhea, pain, abdomen, jaundice, unexplained fatigue. Very rarely you can have bleeding manifestation. And the first 3, that is nausea, vomiting, anorexia, and pain, abdomen, is almost seen in 50 to 75% of the case. And these are the symptoms also common to gastritis. So whenever you have such symptom, you should examine the liver function test also. So how do you manage such a case? So if there are symptoms of DILI such as nausea, vomiting, abdominal pain, or unexplained then you do the blood examination. If the ALT is more than 5 times of the upper limit of normal in a child without symptoms, or if the ALT is more than 3 times the upper limits of normal with symptoms, or if the child has jaundice, then your DILI is confirmed. Then what you do, you stop ATD therapy. You can start with levofloxacin, streptomycin, ethambutol, because these are the 3 drugs, levofloxacin, streptomycin, ethambutol, does not cause any damage to the liver. If the patient is sick, what do you mean by the sick patient? If the child has a life-threatening TB, then you cannot stop ATD altogether. You should put the child on some form of therapy which does not cause further hepatotoxicity. So what do you mean by life-threatening TB? If the child has a chance of death due to TB, or if the child has chances of developing a severe long-lasting morbidity. For example, if you have TB of the spine, it is a life-threatening TB, but whereas a TB of the, say, bones of the hands, dactylitis, it is not a life-threatening TB. So if it is a life-threatening TB, you have to put the child on some form of therapy, but that therapy should not affect the liver. So what we do, usually if the child is very sick, we put the child on levofloxacin, streptomycin, and ethambutol. And we wait for 7 days. After 7 days, you repeat again the liver function test, particularly ALT. And in most of the cases, you will find ALT is less than 2 times of the upper limits of normal. If it is less than 2 times of the upper limits of normal, then you start with rifampicin full dose. Again, wait for 3 days. Only rifampicin is going on full dose. Again, wait for 3 days. Then you again repeat a LFT. And if the LFT is still below 2 times the upper limit of normal, then add INH. Then again, repeat LFT after 3 to 7 days. And if it is less than 2, then add pyrazinamide. But during any of the steps, if there's a resurgence of ALT more than 5 times the upper limit of normal, or if there is a reappearance of jaundice, then you omit the offending drug. And once you omit the offending drug, you have to modify the regime. So you have to give good number of drugs. So this is in short how do you deal with a case of DILI, that is drug-induced liver damage. And before you do this thing, take care whether the child is not suffering from any hepatotrophic virus. So it is always better you should get a common hepatotrophic virus, a test done for hepatitis B, C, and hepatitis A. Usually we do it. So for deciding the final duration of therapy, this is very important. Do not take into account the number of days the full complement of the original treatment is not given. Previously, we are taught that supposing we are stopping therapy for 3 or 7 days, then you have to add these 3 or 7 days after completion of the 6 months of therapy. But no, you need not give extra treatment for 3 of the days you have missed. So with this, I thank you for your patient hearing. And in the next class, Dr. Khya Ghosh-Uttam will be taking the other things. So I think I should stop sharing.
তো ঋতুপদ তাহলে কতদিন স্টপ করলে
যদি if you stop therapy for 4 weeks, less than 4 weeks, you need not do anything. You continue with the treatment you are giving. But in any if your stoppage of treatment is more than 4 weeks, then you have to reinvestigate 2 things: whether the child is suffering from active TB, and if he is suffering from active TB, whether you are dealing with the drug-resistant TB.
I'm not saying that.
Then you have to give the full course of treatment.
I'm saying that suppose someone has stopped for 25 days. Do I need to give that 25 days extra?
No. This is the new thing which has come. You don't have to. Previously, we are taught that after completing 6 months of therapy, these 25 days extra you give at the end. No, you don't have to give extra treatment. You just complete 6 months. That is good enough.
Then why are we giving 6 months? We can give it for 5 months.
This is some. Our entire TB treatment is not individualized. It is done through some standard protocols. So that's the reason. Otherwise, the treatment will differ from place to place. You are very right. Why? What is the difference if you give 5.5 and 6 months? There is actually no difference. So, but it should be standardized, because we follow standardized treatment. In such a huge country, it is not possible. Actually, ideally, what should be done? You should, once you diagnose TB for each patient, you have to see whether the patient is sensitive to all the drugs, then you plan the therapy accordingly. But we never do that. We always give standardized therapy. There are certain protocols we follow. And if you don't follow a protocol, if you don't standardize the treatment, then the treatment will go haywire. So that's the reason why we follow these protocols. Actually, if you see, there's no difference between 5.5 and 6. Can a child on steroid TB with ATD have a paradoxical upgrading reaction at the? Actually, if you give steroid, then the chances of paradoxical reaction is less, because steroid will curtail that immune response. Normally, the immune response is beneficial for the patient, but at times the body doesn't understand. Our system doesn't understand. It goes a little bit ahead of what is needed, doing a little bit more than it's needed. So that's the reason. So chances of starting paradoxical reaction on steroid therapy is much less. So usually we don't get paradoxical reaction, and that's the reason. In case all cases of tuberculosis meningitis, you have to. It's a dictum that you have to give. If you don't give steroids, you will have definitely problems. Such problems you will have. So I think, is there any other question? No, there's no other question. So thank you. Hello.
Not fibro.
Fiber optic. Okay. So thank you. I think we'll leave and thank you again.
আজকে মিটিংটা হ্যালো